Dr. Lowy, I was at the Siteman Cancer Center at Washington University a few months ago, and in just sitting around a table talking with doctors there on the breast cancer topic, they said their view was that maybe that most doctors who deal with breast cancer are coming to the conclusion that chemotherapy is usually not needed, but they don't know how to determine whether it's needed or not, that maybe as many times as 8 out of 10 times that the chemotherapy that a breast cancer patient goes through after surgery, it just wasn't necessary. I want to comment on that generally and other things like that where both the patient and the cost could be dramatically impacted if we just have a little more information and more ways to identify a group of patients that we can clearly would determine you don't need this. You're in the 2 out of 10 that do. You do need it. You're in the 7 or 8 out of 10 that don't. Your thoughts on that would be helpful to me.
Thank you, Senator Blunt. First, I want to thank you, Senator Murray, and your colleagues for the incredible strong support that you have had for NCI and all of NIH. Your question is critically important, and we are optimistic that the future of predictive oncology has enormous potential. The question of how do you deliver the right drug to the right patient at the right time. And an important aspect of that is who should be treated and who should not be treated. We need to do 2 different kinds of research in order to establish that on an evidence-based manner. The first is to do more preclinical studies so that we understand the biological basis for the different prognosis for different patients with breast cancer. And the second is to do clinical research, particularly through understanding large data sets that have been discussed earlier in the hearing, to understand the patient responses and whether patients actually need this through large databases with genomic analyses, et cetera, that Dr. Collins referred to earlier. Through this combination, we will get to the point of being able to tell who is better to give more treatment to and who less.
I think for those of us who are the ultimate lay people but are in part of this discussion, having a few things like that we can mention as possibilities make a difference. It certainly begins to make the case for how this research impacts individuals, how the research impacts overall healthcare cost, how the research leads to more opportunity for people and families, and it's just helpful for us to have. Dr. Hodes, if you know, looking at what you're looking at with Alzheimer's as an example, how much of a factor is determined of how you allocate research dollars based on what you see as a growing problem rather than a more stable problem? Alzheimer's be an example of your numbers. The committee asked you a couple of years ago to do some forward projections on this. You did. If your projections are anywhere close to correct, it's an astronomical problem, and I assume that has impact on how quickly you apply research focus there, but your thoughts on that would be helpful.
Thank you for the question. You summarized yourself very well the projections for cost, and of course the cost isn't just dollars, but above all is human suffering until we are successful. The increased funding that's been provided is being applied to research that's directed according to a plan very much based on best expert opinion, which sets up priorities, milestones, what we need to do each year to achieve, with greatest optimism, at least the goal of the national plan, that is an effective intervention by 2025. It's an aspirational goal. It's a hoped-for goal. And so you're quite right. As we allocate resources in this area, we allocate across a spectrum, the most basic research to discover new targets, because we don't know that what we know now is ultimately what's going to give the best cure. Also the translation of our current best targets into clinical trials. And the great hope we have now, I think, in the field, that by intervening in a way we couldn't just a few years ago at the disease process long before there are symptoms, we have an opportunity to arrest damage before it perhaps occurs irreversibly with death of brain cells and so on. All of this, as you say, driven by the suffering of people today, as well as by the demographic projections of how great this problem will be and even increased magnitude in years to come, because of the success we've had in increasing life expectancy and health span in so many other respects.
Thank you, Senator Murray.